right, cool. Welcome to the podcast. This is episode 1 of season 2. So we've had 10 episodes already in season 1 over the last year. It's crazy how fast it's been. But man, I want to welcome the legend, Matthew here, Matthew Lewis. Welcome to the podcast.
How you guys doing? It's great to be here.
Yeah, we're good. And as always, I feel the need to introduce my co-host, the man, the myth, the legend. Some call him the Tony Stark of chiropractic. I call him Redmond. You call him Redman. Dr. Stephen Redman. Welcome to your own podcast.
Thank you.
Tony Stark,
Glad to have you, Matt.
Yeah,
Yes,
thank you for having me.
He has been called the Tony Stark of chiropractic. Do you want to elaborate on why, Stephen?
Partially because of the glasses, partially because of some of the products the tools I use in the office on patients, but mostly because of the glasses.
The cool thing about Stephen is that you have an undergrad in exercise science, right, Stephen?
Yes.
He also was a registered massage therapist.
Oh, I still am.
The cool thing about Stephen is that he gets the movement theory, he gets biomechanics, applied physiology. He's killer adjuster, chiro. But then at the same time, he's not afraid to use certain passive modalities or, these little kind of tricks, some technology here and there to downregulate pain for his patients in the interim, while he can get them moving. And I think that's fantastic because it's a bit of a dichotomy right now in the industry. You got people that are like, passive treatments are fantastic, and then you got people that are like, passive treatments are the devil. It's like, well, guys, can't we do both?
Yeah, the ability to nuance is completely lost. It seems at times.
That is a very true statement. Anyway, so I'll go ahead and read out a little bit about you, just so our listeners have a bit of a backstory. All right, so Matthew Lewis, PAC, is the owner of Apollo Spine. Matthew first started his medical training at the Philadelphia College of Osteopathic Medicine, where he completed his master's degree in health science and obtained a Physician Assistant certificate. He spent 1 year evaluating and treating patients in the emergency room, including spine and orthopedic emergencies. For the last 3 years, he's been treating patients with chronic back and neck pain, specializing in interventional pain management treatments. During his time there, he noticed that some patients had received every treatment possible, some even surgery, yet still had chronic back pain. Simultaneously, Matthew started studying the work of the legend, Dr. Stuart McGill, a professor of biomechanics at the University of Waterloo in Canada and a world-renowned expert on the lumbar spine. Matthew learned that McGill developed a method to treat lower back pain based on his 35 years of research on lumbar spine biomechanics. He has spent the last 3 years studying his work and is now a McGill Method certified clinician. Wow, that last part is pretty cool. I know a few people that are certified with McGill. Tell me how you got into that. A little bit of the why was there, but tell us a little bit of the why you felt the need to find a solution like McGill, and then also tell us a little bit about the experience of learning from McGill.
Definitely. So I'll go all the way back to the beginning. I had just gotten the job in pain management, kind of something I never saw myself getting into. And meanwhile, I started getting into powerlifting at the same time.
Come
I had
on.
a friend get me in. Yep, I'm actually competing in a competition next weekend. I'm excited. It's my first one. It'll probably go awful, but it'll be fun. So I was getting into that, and then randomly my friends sent me this YouTube video with Stu evaluating a patient. And I was just like, what is he doing? I didn't learn this in school. Like, I don't know any doctor that does this. Then I kind of just started looking into him, started with, the back mechanic, and then, just went on to read everything he had, low back disorders, gift of injury, the spine performance book. And then I was like, oh, I got to go further with this because this stuff is like different than anything I've ever heard. Meanwhile, I'm seeing these patients who are coming for pain management who don't get better. If you're coming to pain management, you don't get better. You stay there. You're a permanent patient, You get all the injections, and then you get these spinal cord stimulators, surgery, whatever, but you're not going anywhere when you get there. And then I was like, this is something different. This is new. This is different. This deserves attention. So when I first started with McGill's courses, it was all online because it was right after COVID started. So did the online stuff, and then did kind of more like Zoom meetings for certifications. But then I had the chance to actually visit McGill at his home. All the clinicians were there this past September evaluating patients together. And, just seeing him in action is just, he gives patients the time and attention that they need. If a patient's been in pain for 10 years, you can't expect to solve the problem in 10 minutes. You got to dig deeper and actually find the pain triggers and teach the patient how to, basic movement proficiency. I mean, I can't tell you the amount of patients that I have who've been in pain for 10, 15 years. They take, hydrocodone every day for pain just to get by. And they can't tell me the first thing about their pain triggers. They're still 100% convinced that the weather is the biggest indicator of their pain from day to day. And that's just, I mean, I'm not saying it has no effect, but if you have a medium day of pain and then it just flares up, I'm sorry, that wasn't the cold weather. That was you moving boxes the day before. Yeah. And I even talked to the patient. They're like, oh, I got a really, really bad day today. I was like, well, what'd you do different? Well, I think it's going to rain later today. I was like, okay, well, what'd you do over the weekend? Oh, I was moving boxes. Maybe that was a little bit more important than the rain later today.
Do you find when people, you're talking to people about triggers, do you find that people have a misconception coming in to seeing you that like every type of manual medicine practitioner should have you like down on the table doing passive treatments or doing massage or doing some type of taping or adjustment or manipulation? Do people ever come to you with that expectation? And do you find it hard for people to listen to you without that intervention? So, for example, I've had people in the past that they haven't taken exercise protocols or movement protocols seriously because they're kind of stuck with this idea that manual medicine people are hands-on.
So I wouldn't consider myself a manual medicine. I mean, I don't have any manual skills. I mean, this goes back to the osteopathic part of it, where PA school, we don't get any osteopathic manipulation training like a DO school. Maybe the philosophy infiltrates the curriculum, but that's not part of it. Mm-hmm. So when patients come to me, they don't expect that. I will say, though, that when it comes to movement proficiency, they think they've already heard it before. Oh, yeah. When I bend down, I should squat instead of, and bend at the knees. That's the way to do it. And they kind of shut off. They don't think that I'm offering something new when I try to kind of teach them about, the McGill method and some other things. So it's taken time to really convince a patient, like, look, this isn't something you've done before.
Yeah, I suppose the way I think of manual medicine is often anything that's not surgical or drug based, in terms of like, you know what I mean? Like I suppose you're not adjusting people and doing stuff like that, but like even with exercise physiologists or athletic trainers, I'd still consider them manual medicine because they're hands-on to an extent. Like you're helping people find ways to move. I suppose that's what I was meaning, but you answered the question pretty much exactly what I was expecting. Like people often expect certain things and they come in with like preconceived ideas, and so you start talking about movement proficiency and they're like, oh yeah, I've seen the infomercials selling me back braces and telling me to keep my bend over and bend my, well, I've been told when I did my first aid certificate that I need to bend my knees. And they're probably less likely to want to listen to you because they think they know it all. How do you get past that? How do you convince people? Do you need to convince people? Like, it's like, well, how does that look?
Yeah, I think it is our job to convince the patient. And it just takes time, honestly. I really try to, I still work full time as a PA, and then I take McGill patients when they're referred to me.
Yep.
But the patients that I see full time, I only get 15 minutes with them. So I'm still trying. I take that time to try to convince them, like, look, go at least read this book, Back Mechanic. Go check this out. And if I have the time, I'll actually show them how a simple, I can remove their pain instantly. And so for some patients, I've been able to like show them that, look, you bent over like this, that caused pain. You did it like this, there was no pain. Like what? Like, and some patients get that connection. It's like the neurons firing, and they're like, "Wow, if I can do that, what else can I do?" When other patients blow it off, like, "Oh, no big deal." So it's hard. It's hard.
If your patient comes to you and they say to you, "Well, like you say to them, do you have good and bad days?" And they say, "Yeah, I do." You're like, "Well, there you go." Like if you're having good and bad days, then there's variables. And
That's exactly what I say.
We can find those variables and we can modulate and regress or progress certain things in your life to help you move better and help you to avoid things.
Who in the world knows what a PA is other than
we don't have them in New Zealand, as far as
you're not a nurse, you're not a physician, you're not a physician's assistant.
Yeah. Well,
Yeah.
hey,
That's all right.
you got to
Everyone makes
help
that
us.
mistake. Yes, yes. So yeah, yeah, you're not alone because not many people know what PAs are. Yeah, I mean, they're called PAs in the US. I mean, even that's changing. They want to be called physician associates. Whether or not you agree, people, the doctors actually don't like that. They
Of
call it
course.
scope. They call it scope creep when you're trying to like get more independence. Um, so well, that's I don't really have an opinion on that, but because I don't care anyway. I feel like I know more than most doctors don't know anything about movement proficiency that I've talked to.
Yep.
So to me, it doesn't matter because I can be an exercise physiologist or I can be a PA that does movement proficiency, and that's going to help better than the injections that you're giving them.
Yep.
So most of the time, anyway.
Yep.
But yeah, so a PA is started in the 60s. These Army, I think they were Army medics that were just basically trained to be general practitioners so that they could, diagnose, treat, prescribe medications. Um, so the original design was to help physicians to have another general practitioner. So we would have a medical license, able to do all these things, interpret radiology, order radiology, things like that. I pretty much do anything that a doctor might do, but I have to work under the legal supervision. And supervision doesn't mean he's over my back or reading everything I do. It's just like an agreement that happens before I start to practice. And then after that, it's more of a collaboration. If I have a question, I ask my supervising physician. If I don't, then I treat the way that I want to treat. We function similar to a nurse practitioner. It just varies state by state whether or not the rules governing us. I know in other countries, like I have a friend from Kenya, and in Kenya they're just called like junior doctors.
I'm still trying to get my head around it. So, do you perform surgery?
So if we're in the surgical field, then we are the first assist. We are not doing the surgery by ourselves. The surgeon is there, he's directing. That's completely dependent on the relationship with the surgeon. If you have a good relationship with the surgeon, he might let you open, perform parts of the procedures during the surgery, close. That's entirely dependent upon the relationship. Like I've known PAs in cardiovascular surgery, and they're doing part of the anastomosis when it comes to a coronary artery bypass graft. Obviously, with the surgeon present, because they're not going to do that on their own. But it really is dependent upon that agreement, that relationship with the physician. But no, generally, we're not surgeons.
But you're fully licensed under the scope of your supervisor to do parts of the surgery if they deem
Yes,
necessary. That's
yes,
pretty
yes,
cool.
yeah,
And what about prescribing pharmaceutical
yeah.
stuff,
I can prescribe anything a
drugs?
doctor can prescribe.
Well, that's pretty cool. Although,
Yeah,
like,
unfortunately, I prescribe like narcotics almost all day because
yeah,
I,
and
because I still work in the pain clinic, and
okay.
unfortunately, some of the patients, I can't. I wish that I could teach them the McGill method, but I can't convince them to do it, or they're convinced that they're a pain patient for life. So
Do you see yourself going full time into the McGill method, or do you think you'll split your time for indefinite amount of time?
if I had enough patients with McGill method, I would go
Yeah.
full time.
Okay.
But yeah, that's a good question. Really, this has sprung me into not just, other solutions for the low back, but for the whole musculoskeletal system. So that's why I'm getting into, SFMA. I'm really big into clinical
Okay.
neurodynamics with Michael Shacklock. So I'd love to have a clinic.
So
Yeah, go ahead.
SFMA and NDS. Anything else you've been looking into?
Some things that are on a radar, but not into yet. So like I mentioned that I don't have any um, I didn't learn any joint manipulation or mobilization in school. That's not part of PA school or any medical school unless you're an osteopath. So on my list is, learning some sort of, whether it's soft tissue mobilization like ART or dry needling, something just to have that in my wheelhouse to be able to use.
Hey, Steven's the right guy to talk to about that stuff because he's got his head right into all that. He knows every
Good.
three-letter acronym on this earth.
All right, I
Not
guess
every,
we'll
but
have to talk. I'll have to talk to you. I'm South Carolina. Wait, you're South Carolina, right?
yeah.
Yeah, that's not too far. That's like 6 hours, 6 to 8 hours
Yeah,
maybe.
I'm actually doing a program through the University of Pittsburgh. It starts technically in April, and it's all asynchronous except for like a couple of weekends are virtual, and then there's one in-person one in
Mhm.
Pittsburgh. And I'm from South Carolina, and it's in December, so I'm going to be freezing cold that weekend in December in Pittsburgh.
Oh, what's the program?
It's called the Primary Spine Practitioner Program. It's through
Hmm,
their rehab department.
that's
It's
awesome.
geared towards like PTs and chiros to help them like better communicate with MDs to like, handle the non-surgical cases, kind of like what you're doing with the McGill method, NPA, and what David Johnson wants to do in New Zealand, where
Yeah.
there's other providers that the MDs can directly refer to or either have them in-house. Like there, I don't know if you know this, but there's actually some chiropractors in hospitals that function to that capacity already. It's not
That's
a lot,
awesome.
but it is a
Yeah.
thing.
Well, another time I'd like to hear like about that in detail. That sounds very interesting.
Like you
Yeah.
can go ahead and give it to us, man. I'm interested to know as well. Like what is the point? What is the goal? What is the end goal of doing this certification for you? Like what is it going to allow you to do that you can't do now?
It's going to help me learn how to better create and manage long-term relationships with those pain management docs, with those orthos, with those neuros to co-manage patients or maybe take the lead on cases, maybe they take the lead on cases, and then just have a revolving referral window where, hey, this patient needs to go see you, or hey, this patient needs to come see me,
Yeah.
and just back and forth. That way, we prevent these lifelong pain management patients. Because I mean, like Matt said, like when people go to pain management, that's the end. Like they'll go indefinitely. They'll have periods where they don't go, but then they'll get drawn back in because they'll have too many bad days. A hurricane will come through and they're like, oh, time for pain management. My back's just done or my knee's done.
Hey, we just had a massive
Yeah.
cyclone in New Zealand. It was the third time in our history that we declared a national emergency, state of national emergency. So it was pretty
Wow.
full on. Yeah. No, that's interesting, Stephen. And for our listeners, and even our listeners probably know, but for you, Matthew, Stephen tends to have a bit of a history of picking things up that other chiropractors might not pick up, and then kind of like annoying people's like primary doctors with things that he's found. And they're like, "You're a chiro. Like, why are you talking to me about blood work?" But
Yeah.
um,
That's
you
cool
know,
though.
it is cool.
Yeah,
Picking
so
up things is cool. I mean, I know, Stephen, you probably can't talk about the specifics on the podcast, but being able to pick something up that you wouldn't expect a chiropractor to pick up and multiple other healthcare professionals have not picked up, that's fucking cool. Like, I don't know, but that's just cool.
Yeah, I mean that's hope for a patient, you know?
yeah,
It's not just a cool finding. That's for a patient. That is the difference between a life of pain or a life of, flourishing.
This is interesting. I'm learning a lot, especially about the PAC thing. I think what interests me the most is how you're talking about almost kind of like what you're doing, like your day job as a PAC in a pain clinic. You're kind of seeing a lot of what's wrong in the medical system. Is that fair to say?
Yeah, I mean that's really the reason I know that it's so wrong. And that's why McGill is like I stuck to McGill like a magnet because I'm like, I see how it's being treated here, and then I see how it can be treated. Your entire perspective changes when you have people come to you every day with pain. And I'm 30 patients a day. And they're asking for more Percocet. They're asking for something stronger for pain. And I
Wow.
don't blame them because they've gone through everything. I mean, some of them are just drug seeking and I distrust them. But other patients, they've gone through everything. They've gone to physio, they've gone to chiro, they've gone to even a surgeon who said either they had surgery or they're not a candidate for surgery. And so I don't blame them. So that changes your entire perspective, like on life, especially on my career, but on life too. And you're seeing so many people in pain. You're like, why are so many people in pain? And then
Mm.
so McGill stuff is just that
Well,
just
people
that just hit home with me.
they tend to get they tend to fall through the metaphorical cracks or gaps of the medical system. And I think one of the cool things about McGill and some of these other things that we're talking about that is so inspiring is that it's a way to help people you're not cutting into them and you're not giving them pills and drugs, and it's this kind of paradigm shift that we're told. And I know so many people I talk to, when you talk about medicine, like what they think healthcare is sick care. Like their perception of healthcare is sick care, right? It's symptom care. Like a lot of people don't kind of have that understanding of like what true healthcare kind of looks like. And I suppose parts of the osteopathic and parts of the chiropractic history, although there are some dubious not so great parts of those in the history of those careers, there is some real benefits as well with their holistic view of certain things, especially with the body. And I think it's just so cool that you have this kind of skill set that you've gone out on your own. You know, you've seen that there's an issue, and you've gone out and you've found the education, you've found the right person to give you the skills, and now you have the ability to do that. And so what I was wanting to say before is that if anyone who's listening to this podcast, if you are a chiro, an osteo, an MD, you know, an exercise physiologist, whatever you are, athletic trainer, athletic therapist, and you are needing someone to cross-refer to or refer to or to talk to a case about, and you're in the same area as Matthew, reach out, right? Matthew, like,
definitely.
Where can people find you? Just give people your Instagram, and like, what's the fastest way someone could reach you if they wanted to chat to you about more about this?
Yeah, Instagram, Apollo Spine. My email is apollospinenj@gmail.com. You know.
Yep. And where are you exactly? Like, where's your exact location?
I'm in New Jersey, South Jersey, close to Philadelphia.
I just wanted to get that out there just because David Johnson often says our strength is in the collaboration, and you should have 30 McGill clients, you know, not 30 pain clients. Although saying that, McGill is a lot long, like rather than 15 minutes, it's like 3 hours.
There's not enough hours in the day.
Yeah, but you know what I mean.
I could see 2 a day.
Yeah. You should be booked out with your McGill stuff, because of your knowledge. There's people that need that care. There's people that, like you said, are in pain, going through this pain cycle and this prescription pain cycle of taking meds and whatnot. For a lot of these people, their only opportunity to get better is the protocols that we know. And I often think about how urgent that is, like, especially when you're dealing with general population. It's like, man, your roster should be filled, because we need more people like you in this medical industry. And often we'll have one or two guests on our podcast, and Stephen can confirm, we're all saying the same problem with medical stuff. I mean, I'm in New Zealand, I'm on the other side of the world, and sometimes we have people from Australia, sometimes we have people from America, and we are usually all sitting here pretty much talking about the same problems with the medical model, traditionally speaking. Mm-hmm. So that's pretty sobering, isn't it? And to hear your story about people that are coming to you who are in pain, it makes it really real, eh? Like, it really takes you out of, it's just so easy to get caught up in arguing about like positions and things on social media about what is effective and what is not. And it's like, man, so many of us healthcare professionals need to take a step back and be like, this is for people who are in actual extreme pain. And when you're seeing people every day, like you said, it obviously becomes very real for you. So can you talk a little more about, are you like legally unable to take patients from the pain clinic into your private McGill type practice, or is it more just that it's just hard to convince them because they're on this drip of pharmaceutical drugs?
I have taken patients from the pain clinic and said, look, you know, you don't want to go down this path of just doing forever epidurals and oxycodone every day. Like, there is a better method. To be honest, because my day gets so packed, I tend to hand select patients, and I'm like, this patient is going to listen to what I have to say, and they're going to actually take it, and they'd be interested. Whereas most of my patients, you know, when you're on disability and you just assume that the healthcare system is going to take care of you, when someone comes to you and says that you have a new method, but it costs money out of pocket, you know, they're not really ready to hear that. Because, I mean, unfortunately, I can't really get paid for what I do through insurance right now. I don't know how to do that to even make money, to have a living. My goal in McGill stuff is not to get rich by any means. Like, you don't get rich seeing 2 patients a day, but just to earn a living, I would do this every day.
Isn't that an interesting paradigm to accept, though? Like, when you want to make money, and I know I'm not picking on chiropractors, but just because of my experience, man, the model that was taught to us, and we were encouraged to do a model that was rack and crack, you know, don't do anything else. I had professors telling me, like, trust me, you don't want to get into movement therapy, and you don't want to get into that, and sports stuff and tissue stuff. The longer you have them on the table,
it's not sexy.
All you have to do is, pretty much, they were saying to me in so many words, rack 'em, crack 'em. And I've told this story on this before, but a certain individual that was in a position of power at our college would talk to us about how he got the patient visits down to 2 minutes.
Yeah.
Yeah, exactly. No words.
Yeah.
And I know even for someone like Stephen, with like even Stephen, if you want to even give us a little bit of an insight, because I think it would be interesting to hear, you worked at a high volume clinic for a few years, right? And
Yeah.
but you were required to see people over very short amounts of time. So how did you navigate that? It's very relevant to this conversation.
It took a lot of practice because
I bet.
those visits were very quick. So we'll leave
Explain.
it unnamed for the episode. But yeah, so visits there, it's supposed to be 5 minutes or less from the time you walk up, grab the patient, bring them back, adjust them, do the note, send them back up. It's supposed to be 5 minutes or less.
Hmm.
Wait,
Yeah,
how long?
It's 5 minutes or less.
Oh
My
my.
visits were
crazy.
generally about 7 minutes, and I was always told I could be a little bit quicker. I was never forced to be quicker because I was very thorough and I was doing stuff no one else was. Like most of the chiropractors there were not touching anything outside the axial spine. There's a lot of stuff on the appendicular spine that can present as axial spine dysfunction. So I'm looking at everything. I'm touching
Yeah.
everything. So it took me an extra 3 minutes on average per patient. So people could see twice as many patients as I could in the same amount of time in theory, almost.
Oh my gosh, that's
But I
crazy.
would still see like on average 50 patients a day in 9 hours.
50.
Or
Jeez.
then on a Saturday, I could see the same amount of patients, but at a quicker volume because it's 6 hours as opposed to 9 hours. So I could see 50 people in 6 hours, up to 65 in 6 hours, or I could see between like 35 and 75 in a 9 hour day.
Yeah. And there's probably part of the population where that works. They get their,
Yeah, yeah,
they get their weekly crack and they're good.
yes.
But for the
That's
patients
exactly
that,
what they market. They market a weekly crack. It's like $80 a month. You pop in four
yeah,
times a month, so once a week, and it's $80 flat rate.
that's pretty
And then
cheap.
it's $10 extra. It's very, very cheap, but it's because you're only getting racked and cracked.
Yeah. And for
You're
that
not
patient,
supposed to do.
that's not such a, yeah, that could be a good thing. But
Yeah, yeah, it's a good thing for a lot of people, but for a lot
if
of
you're
people, it's
still in
also not a
pain,
good thing.
then if you're still in pain, you need someone to take a closer look at your back.
That's the issue, right? It's when they don't have an off
Yeah,
ramp or there's no education on giving them any strategies on how to move better because they're coming. This just happened with someone. Me and Steven are constantly sending each other like videos or whatever and laughing about stuff. But this just happened with someone who had a stiff back, went to see someone. He cracked him head to toe like a glow stick. And then they were like, oh yeah, maybe I shouldn't be any more specific. But the
yeah,
point is, right, is how do you give people, how do you empower people? How do you give them something that they can do that's going to allow them to downregulate pain, move better, feel better, move well, and maybe even move well under load, which would be fantastic, as we know the benefits of not only cardiovascular cardio type training, but we now understand the incredible long list of benefits from actual resistance training, right? Actual strength training.
Yeah. Yeah.
So it's
Longevity. Yeah.
absolutely right. And so giving people those tools, that's the key. But so many practitioners, certain types of practitioners will shy away from that because in their model, if you have them coming back for the crack, it's like they're coming back for the oxy to you. They're coming back for a short-term modulation. Now, I say to people, if you're helping people get out of pain and you're not using drugs or surgery, that's a good thing. But then everything, like you said before, right, like with nuance and context, everything's within context because if someone's treating it like that and they're coming in weekly or whatever, they're not getting better, and you're just constantly hitting the same old stress points, and then they're going out and making it worse. They're going to have you're likely going to create a hypermobility, which can happen, and Stephen's probably seen that. You're probably likely going to be encouraging even more degeneration of the spine because they're not only they're getting adjusted in these areas, being hypermobile, they're going out now with less stability, less ability, and now they're doing the same thing over and over and over. And so this cycle is what's going to cause them to have disability eventually. So it's like, how do you get people? How do you even educate people? How do you find the off ramp? I often call it like the off ramp. How do we get people to a point where they're pain free, they're moving well, they're moving better, and then they can manage themselves? And I suppose, Stephen, you've talked about this before about how you will you will change the type of interventions you give your patient based on your kind of quick fire assessment of how likely they are to do certain things.
Yeah. So if I have a patient who seems very on top of it, then I am very careful at how I prescribe stuff, but I will prescribe them to do certain things, or we'll do certain things in the office, and I will kind of throttle them back a little bit because I know that they're going to go out and do the shotgun approach. They're going to do everything that I just did with them, plus more. They're going to overdo it. So I scale them back. I don't show them too much yet because I know that they're going to overdo it, overload it, and potentially make things worse. But then if they're not so on board with it, I will like show them a little bit and I'll tell them there's a whole lot more down the road. We have to start here and then we find the things that they're most likely to do. And I will reiterate several times through the visit, gauging them as we go along and asking them how comfortable they are with it, or if they don't want to continue doing these types of things. And I tell them to be honest with me, and they always are, or at least I think they are, and they seem to be according to how they present at the follow-up visit. I I really stress that I need to know how much they want to take control of it and how much they want to leave to me and natural healing. Because the
Yeah.
more that I know that, the more I can progress or regress everything, get a little more aggressive, all that. Like I had a patient, new patient, just a couple weeks ago. He's at military college here. He's a freshman, so he's literally running around all day. He's got a Haglund's deformity on his heel, and he's developed a true IT band syndrome. And there's just not enough time in his day or in my day. So I'm like, here's what we need to do. What can you do? And then I gave him some of my supplies that I keep and I use with patients. Like I do that sometimes. I like literally just give away my stuff to patients if I feel like they're going to be able to squeeze in 5 sets of it
Yeah.
in 8 hours somewhere somehow. I will like give them my tools and say, here, go do this. But I've shown you how to do it. Go do this. But other patients, I know if I do that, it's gonna get tossed aside. It may even end up in the trash. So I really have to gauge where they're at, where they want to go, constantly rechecking that as we go through that visit and then that follow-up visit.
The cool thing about that is the ability for a practitioner or a therapist or a doctor to be self-aware and being able to be self-aware enough to not, because you get some people that will just prescribe stuff and they'll go, well, it's not my problem if they don't do it. I've given them the tools. I can't, I can only lead the horse to water. I can't make you drink. Now that kind of mentality I have a real issue with. I know McGill also has a very strong opinion, similar to what Stephen just explained. So from you, Matthew, what are your thoughts on practitioners and doctors being self-aware enough to really hone in and to understand one's personality and how they may or may not respond to the types of exercises or interventions that you prescribe them?
Yeah, I think that's our job, to convince them that something is important.
Yeah, exactly.
I mean, it's hard. You're dealing with people, and people have ideas and beliefs, and so different things influence them. But I think if the patient didn't do it, I think at some point it comes down to a failure on us. It puts a lot of weight on us, but at the same time, we can't just throw it away and say, well, they didn't listen. And that's what I'm trained. That's what I'm originally trained to do. I'll give you the prescription. You don't take it. That's your fault. But if we're going to be like actually competent clinicians that are seeing the person in front of you as a human being, I don't know. It's my job to convince you. That's what I think.
I like that mindset, and I think too often people like, for example, right? This is how I'll get my point across. When we were talking to David Johnson and Dr. Locke regarding surgery, they were talking a lot about how people will have surgery and then they'll say, oh, the surgery is 50% likely to work, say, based on the statistics, right? And they'll say, okay, is it failed surgery or is it failed rehab following the surgery? Because if you, going back to adjacent disc disease, if you are going to fix the symptom, you're going to lock down and stabilize that joint that's causing the issues. But you're going to continue to move wrong with movement dysfunction. Those forces are going to migrate to the next available joint upwards or downwards in the system, right? That's what they've been saying. And so in that situation, where's like the blame, so many will blame the surgery or blame the surgeon, being like, well, surgeries only work for half the time, or, some surgeries are placebo or whatever, right? But in actuality, we as practitioners or therapists or doctors, once again, going back full circle to the ability to be self-aware enough, right, to take note and be like, no, a lot of this is actually on me. If someone's coming to see me for a rehab purpose post-surgery, rather than just doing the basic thing, or even following the guidelines, right, even following a lot of the board guidelines that are distributed worldwide, internationally, in America, Australia, New Zealand, a lot of them are very similar and written by people who have never done a deadlift or a squat or an overhead press in their life. And you try and publish, even with our journals, we've been published trying to get our research published, and we will come up against a wall with people that are like, what's movement proficiency? It doesn't exist. You're like, well, of course you don't get it. You're the editor of this paper, and you've never got, every night you go home with a beer and you sit on your ass. You've never done a squat in your life. You're a lazy. So of course you're not going to get the point, So it's like really like Dr. David often says, when we're looking to hire movement therapists, rather than looking at their resume, we're looking at their hands. Are there calluses on their hands? And obviously that's just a saying, but you get the point behind the saying. It's just saying like, hey, these people that are setting these guidelines, are they the same ones that actually understand how to move and that have actually seen their patients move better and feel better and have less pain? And they're not. They're usually the ones that are prescribing drugs, and they're usually the people that are just doing surgery after surgery after surgery. And I find that to be an extreme problem. What are your thoughts on that?
All the doctors I work with, anesthesiologists and PM&R doctors, physical medicine and rehabilitation doctors, I can't say that any of them squat. I talked to one anesthesiologist, and he's a great doctor, great anesthesiologist, but he said like doing a squat is putting your disc at most risk for injury based on that one study that showed that sitting to standing put the most pressure on a disc. When I was like, well, that really is not complete. I mean, that's completely out of context.
Is that the 80s intradisc Pascal intradisc studies?
Yeah. So like they would recommend to patients not to squat because of something like that. But that's, obviously that lacks complete context of whether or not the spine is able to tolerate that load based on prior loading. If they have a bracing strategy, if it's in the neutral versus the flex spine,
But it's interesting when people cite the intradisc pressure studies, because like he's saying, well, sitting down and standing up is going to put pressure on the spine. And it's like, yeah, but we know based on the hydraulic function of the nucleus propulsus within the annulus fibrosus and the way that the associated muscles to do with that, and the way McGill will actually call them guy wire system, as you know. But we understand, like, if the spine's neutral and we're dealing with compressive force, the spine's relatively good at dispersing that, It's obviously when you're moving in one specific direction, and you go into extension, you have people having facet issues and spondy issues, and then in flexion, you're having your herniated disc, and then with compression, you're still having end plate problems. There's still issues, and there's actually studies out there that show that you can still have injuries in a neutral spine. They still occur, but it's just the likelihood and the amount of research that has shown the mechanism of flexion to be in terms of the herniated disc. It's so hard to ignore all of that literature, but every gym bro, or I should say gym physio almost now, every physio or sports physio online in the comments section will say that McGill is outdated, or that it's dead pig spines. And I hate to say that because it's wrong, it's out of context. I even read somewhere that 5 to 10% of McGill's work was with cadavers, as in the average person who's saying that stuff likely doesn't work, probably they actually think the entirety of his work was cadaver work. They don't realize that he did MRI studies, he did legit trials with powerlifters, fluoroscopy studies, he did biopsies, all these different
CV is
stuff.
massive. It's like 200 some pages.
Exactly. 240 like peer-reviewed journals articles.
Yeah.
And they think it's just, and it all gets put into this lumped under dead pig spines by many people.
The world would be a much better place if people were able to actually listen to what the other person is saying and critically analyze it and say either that makes sense or no, I disagree with it because of this, as opposed to this craziness with name calling and whatever you call it. But it's
exactly. But what happens is you get these people that they feel like it's there are certain physios online that feel like it's their job to call out pseudoscience. And so they say, like, as physios that have a license, board certified physios, it's our responsibility to call these people out. And so what you'll get is that's their justification for being pretty much abusive, like harassment. I try to stay out of it. I don't engage in it, but when your name is thrown around with some of those other guys, it's impossible. You're going to get hit. Anyway, okay, so back to what we were talking about. I actually have a friend in his 4th year of chiropractic, and he takes out patients into the back room, does McGill stuff, and
Nice.
because they're not even doing, like, for example, like a lot of what Stephen would do today in his practice, you were able to have the education of MPI, which helped you be the practitioner you are now, because MPI is great. That doesn't, of course, you do more now and whatnot, but in New Zealand, we don't have that. We don't have any biomechanical based, evidence-based, evidence-informed chiropractic protocols. So everything we're learning is old school. And so the point of my example was that my friend has to use these old school methods. And so he started implementing movement theory, started implementing the MPS, which is the movement proficiency scale, which is me and Aaron created that. And then he's also started using McGill stuff, and he just takes them out back and he'll just do that. Yeah, it's a true story, man. I interrupt this podcast to thank Raisies for sponsoring the Strength and Chiro podcast. Raisies is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well, and contains no additives or nasty preservatives, this is for you. This protein is New Zealand-made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it is essential that you get an adequate amount of protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz. And his patients now have been getting better. In a similar parallel to you, what is the criteria when you're dealing with 30 patients a day for you to pick out people that you think would be open to McGill?
Generally someone who's a little bit more active. Like if I have a patient who's, they're 60 years old, they've been on disability 10 years, they're 100 pounds overweight, they can barely ambulate by themselves. Not really the best McGill patient. It's going to take an hour more just to teach them how to hip hinge, if they even can. They don't have the leg strength to get up from the chair they don't have the leg strength to spare their spine, because they can't get out of a chair without just relying on passive tissue. So really the patient is like anyone that is somewhat active, if you can walk. And also they don't have the victim mentality, because not that they can't, not that I can't convince them, but I know it's going to take a lot more time to convince them that, listen, there's something that you can do. You don't have to be in pain the rest of your life. You actually have the power to do that, and I can help you with that. If you are stuck in thinking you are the victim in life hand you this crappy hand and you have nothing to do with it, and you are totally fixated on that, what I'm saying is not going to be hope to you. That's not going to be hope. But if you are coming to me and you're asking for help and you're saying, I need to try something else, I need help, that person is ready to listen what I have to say, because they're looking for an answer. They're ready to hear something that's hopeful.
They're open to it. What is their reaction when you sit down and you do a 3-hour assessment with them? And furthermore, why do you think it's important that you have that time with a patient?
Yeah, I mean, every single patient I've ever seen that I've given them the time, they're like, wow, no one's ever spent that much time with me. No one's ever explained that to me. No one's ever showed me that. No one's ever told me that. I get that all the time, that no one's ever done X, Y, Z. It's just because the medical system doesn't even allow for that. 15-minute visits, and even in therapy, like physical therapy is where they should be getting this, because this is an hour that the therapist gets with the patient. But unfortunately, I don't know how it is in New Zealand, but in the US, most therapy companies, they're seeing the therapists are forced to see 3 to 4 patients per hour. So that patient's not going to get, they're not being watched to see if they're being movement proficient at all. If anything, they're just given exercises that are time killers. It's just fluff just to kill the time.
Yeah, and you see how people misrepresent McGill's position on stability, you know, and core exercises and coordination and muscle sequencing because PTs have given them like, bro, can you actually speak on this as well, in your opinion, how McGill and his process has been watered down to these generic magazine articles or physio articles, and then now you've got personal trainers and physios that are prescribing bird dogs out of context, randomly, arbitrary for people that, and they're saying, oh, you know, they got a weak core, and now we're at the point where people are saying McGill's been misrepresented, and people are like, well, the whole weak core thing's not actually legit. Like, how have you seen that process? Have you seen how it's gotten to that point? How so many people, you've just got all these people using McGill now, they're just throwing the McGill 3, and they think that's the McGill method.
Yeah. I mean, obviously, most people don't really understand or know what the McGill method actually is. You know, I guess if you're just in that arena, you just think it's 3 exercises. But really, at the heart of McGill is a thorough assessment. That's where it starts. I mean, that is really the heart of what the McGill method. It's not even the McGill method isn't even movement proficiency or the McGill Big 3. It really at the heart is a thorough assessment that you understand the mechanism of pain and how the patient can wind down the pain. That's really the heart of it.
Exactly. And that makes a lot of sense. And so for people that are listening, what would be the best resource to learn about McGill, in your opinion? Just for people that don't know much about him, where would you send them? And 2, for people that have heard a bit about him but want to dig deeper.
Yeah. I mean, he wrote a book specifically for patients, and it's called Back Mechanic. You know, I tell my patients, I have one.
Yeah, I've got it somewhere. Grab it. Yeah, I've got it somewhere. No, I've got it somewhere as well. I love it. I've read it a few times. In fact, I've just read that
right here,
and I've read lower back disorders, and then also just read the sports one, which was good.
Yeah, so I mean, he specifically wrote that for patients to follow, and obviously you're not going to get the same assessment reading the book than you are having a competent clinician look at your back. But as a start, it's better reading the book. Reading Back Mechanic on your own is better than going to the best sports medicine doctor in your area that has no idea what they're talking about when it comes to movement proficiency. So it's a better start than going to your local family doctor or sports medicine doctor.
And when you do your protocols, do you do traditional orthopedic tests still, or do you use McGill's kind of sitting on the chair, slump test, extended test, getting, you know, he does the dynamic test, like dropping on your heels? Because I found like his system, McGill type orthos, because that's really what it is, right? They're just kind of like orthopedic tests. I find those extremely useful, and I really found that book really useful. When I read Lower Back Disorders, I read one of the original older ones, one of the first or second edition, and in the back it had like old school orthopedic tests. So when you, within your scope of what you learned, does he teach you the McGill stuff and other, like, I'm talking straight leg raise, Bechterew, Lagou's test? Like, do you do any other traditional tests for herniated discs?
For sure. So I start with what Stu calls the seated compression test. And that's what he recommends, starting with seated compression. So you're testing neutral, flexion, extension, and then you're modulating neural tension in those positions. Yep. So I might have the patient, slump or flex and then add load to it. And then I'm going to change neural tension to see if that, creates the numbness in their feet that they have.
Yeah.
And then something that I don't know if you've ever heard him talk, but he does something called playing jazz. That's what he likes to call it. So when he has a patient in position and he finds pain, he just plays with it. So that's kind of thing that's been interesting to watch. But anyway, I start with a seated compression test, and then I'll do your basic straight leg raise, the slump test, your Kemp test or the facet maneuver. But I don't know if it's in the book, but there is a facet maneuver that he does where you do the facet maneuver first, and then you have the patient stand on one leg, and then you repeat the facet maneuver.
Is that similar to Storks, the traditional one?
That's what it sounds like.
The thing I really found the South taught orthos that he put in the book.
Back mechanic.
Yeah, sorry, back mechanic. I've read that about 3 times. Yeah, and so he goes through all the seated ones. So for people that don't know who are listening, he goes through and he teaches you: sit on a chair, flex forward, flex back, pull down, compression. He gets you to test these things because he's trying to find what's provoking the pain. And I find those really useful compared to traditional ones. But just touching on that, he will also get you to modulate your neck, the movement of your neck, right? Because to see whether you've got an overhook or an underhook. And obviously, like flexion is the traditional overhook. Can you talk? I'm not sure how much you know about this specifically because it is a real specific question, but could you talk a little more about the underhook? Because I've found a lot of people are confused. So say you flex over and then he gets you to extend and you're flushing the neural cord downward, it's going to aggravate because there's a herniation under the nerve root.
Exactly. Yeah, I mean, you've said it just right. Most of the time you flex the neck and the herniation sits above the nerve so that when you pull up the nerve with neck flexion, it runs into the herniation or the disc, and that causes the pain. Now, what happens if the nerve is running here and the herniation is sitting underneath the nerve? Yeah. And then now you extend the neck and that drops the nerve down. Now it's running into the herniation. So, and it's also a way of how you're describing it. If you listen to Michael Shacklock, for him, this is the proximal sliding dysfunction versus the distal sliding dysfunction. Yeah. They're explaining the same thing, but they have different names.
And what about, have you heard people talk about it in terms of like medial and lateral herniation?
No, not specifically.
Because there is a way that I'm just trying to actually locate the image for you. But in chiro school, and Stephen, you'd know like this, like you're taught there's 2 types of main herniations, right? There's a medial and there's a lateral. Medial's under the nerve root, lateral's over the nerve root. And so I've asked multiple McGill practitioners whether there's a like if that's the same thing or not. And people people can't really give me a straight answer. That's why I'm trying to find it for you.
I haven't heard that correlation, but just thinking of it conceptually, I don't see why that would necessarily be the case.
I've got it for you. So in chiro school, we are taught, I'm not sure if Stephen was taught this way, but the curriculum does seem to be quite similar across from the States to New Zealand. You'll see on this side here, so you can see. So you can see that the lateral is above and the medial is under. And so we're taught that if it's a medial, you're going to have them leaning to the same side. And if it's a lateral, you're going to have them leaning away. And that's how they teach us clinically to distinguish between medial and lateral herniations. And we're also taught that a straight leg will do a lateral and that a well leg will do a medial, I think, as well. So there are a couple of things that they teach us in chiro school. Do you think there's any correlation there?
Yeah, I don't know if I can really speak specifically to that. Because, I've talked with Michael Shacklock and you really can't, it doesn't seem like you can really differentiate that.
Yeah, I agree, because when you look into the reality of it, like that's what I was taught black and white in school. And then
in school we were taught that, but then some of the professors would be like, but we can't truly say that concretely. That's the way that it is. It's a good theory, but we can't prove
I don't know if it's actually been tested, if there's been any trials on that.
In reality, it's more like that. You know what I mean? Like in reality, it can pop up anywhere. Like it's not going to be like lateral and medial, and you're going to treat it this way. Like in reality, it can be a herniation.
And it's not just a black and white thing. It's not medial or lateral. It's really central, paracentral, foraminal, and then extraforaminal. Like there's not really one category.
Yeah, and we learned that in neuro. So we actually did learn that in neuro, but then we learned the basic one in chiro technique, maybe. I don't know. Anyway, I thought that would be an interesting thing to ask about, because I've had a few conversations with people before, and people get like, it's quite confusing for people to understand why the neck modulates the pain. I've heard people, but it's a great test. And so talking about that, I really wanted to ask you: have you had that? Have you ever had it?
Oh, definitely. Yeah.
Wow.
Yeah,
okay.
Definitely.
It's less likely, right?
I mean, they say it's about 20, like maybe 20% of all disc herniations, maybe less. I can't remember the number, but yeah, I mean, it's good to have an assistant, because, if you're doing the straight leg raise, and then, you have the assistant kind of pull the neck up and seeing if it makes it worse. And then you have them, you're far enough off the bed that the patient drops their head all the way back into full neck extension. And if that makes it worse, then that's kind of like your your classic underhook.
Yeah, because I suppose if you're doing it in the straight leg position, there's going to be a lot of tension on that nerve root, on the spinal nerve A, opposed to if you do it. I've seen McGill do it like seated, like go flex, pull, and then
Yeah.
which is a little different, just a
Yeah.
little different, same thing, a little different.
Yeah. Yeah. You can do it that way too.
Yeah.
Just different ways of playing with the nerve. Yeah. And Shacklock would have a different way of doing it. Like he won't do the neck flexion extension during straight leg raise generally.
Yeah.
That's a McGill thing.
Yeah, I love McGill stuff. I feel like if you can just read his books, you understand anatomy and you understand his stuff, you're so much better off than most of the degrees out there.
Yeah, I mean that really started me off. That's the only reason I'm here. That's the only reason I've really gotten into this field, and now I'm obsessed with it.
Yeah, it's amazing. And so, in terms of your education, what two questions? What education did you have before you did your PAC? And then also, why did you choose to do it at an osteo school? If that is a reason, or if that's just chance?
Yeah. So before I went to Drexel University in Philadelphia, for a biology degree, because I knew I liked science, but I really didn't know which way I was going to go with it. And then it wasn't until my, I think, junior or senior year of my undergrad that I found out what a PA even was. I had no idea. I just thought, like you, like there's doctors and nurses. That's all I knew. And then I found out there was a PA, which did everything a doctor did, but kind of worked under the supervision of a doctor and had less schooling and no residency. I was like, wow, this sounds pretty cool. I'm gonna check into this. And I was hooked on that. And as far as it being osteopathic, honestly, it really didn't matter to me because I don't think the osteopathic philosophy really leak its way into the PA curriculum, because the curriculum is pretty specific, based on what the governing bodies want to be, based on passing tests. So that curriculum doesn't really leach its way into PA schools. I mean, I'm not part of, obviously not the board or professor of those schools to know like what has influenced them. But I love the school I went to. I heard it was good, and they had like some schools had a cadaver that was already dissected, and so that you would just go into the lab and look at the anatomy based on the cadaver that was dissected by someone else, probably like first year medical students. Whereas at PCOM, we did the dissection ourselves from head to toe, the whole thing. So that was a huge part. It's completely different getting to dissect, getting to physically, scalpel in hand, get in there, get your hands dirty, and dissect and find anatomical regions, as opposed to having it dug out for you and you're just looking at it.
Yeah, I can't say.
There's the guy who doesn't like horror movies.
I just got to observe and look and watch and poke around, but I didn't get to actually dissect. What about you, Stephen?
No, I have never seen the cadaver.
Oh, isn't it part of the curriculum?
Aside from like on YouTube. No, so in my
Yeah.
I did my undergrad biology stuff at a community college, so we just had the textbooks and models. And then in chiropractic school, we had models, and then we had these computers. They're basically 7 foot long tablets, and they were cadavers. But so they went through and they did imaging on like 4 people that were dead, like the cadavers. They took pictures of all the tissues. They did MRIs of all the tissues. They did CTs of all the tissues. You can go and you can pull all of that up. You like pull away the vasculature or certain tissues away and just kind of isolate them. But
That's
That's cool.
that's the closest I've gotten to a cadaver. It was
Yeah.
neat, but it was a little buggy.
Hmm.
But it was neat because it was like a real person. So
I think
between
both
the
would be
4 different
really
bodies.
important,
Yeah,
Yeah.
yeah.
because like that would have been nice too, to have that like 3D where you can kind of like, all right, get rid of the fat, get rid of the
Yeah.
muscle. Let me see where the nerves lie, and then that's really helpful.
Yeah,
I
I
think in
agree.
combination, yeah, because there's nothing like, I remember this. We had the same cadaver the entire semester, so it was our body.
Yeah.
So I remember this dude was a pretty big dude, and his sciatic nerve was like, I'm telling you, this this thing was massive. Like I could hold it like a rope, you know?
Whoa.
So it's a cool thing to be able to be like, yeah, I've kind of squeezed a sciatic nerve,
Yes, that's
like
very
in
good.
person.
We had
Cool.
very like similar to Stephen, we didn't have like the opportunity to have it on site, but one of the richer schools in Auckland were they would allow us to come in and do like pretty much do anything we wanted apart from like dissect stuff. So
Yeah.
we had like fresh cadavers, and then we had like plastic. You know what's it called when that's like they put like a plastic over it? Have you seen those cadavers where it's like it just it like they've been able to just keep it in like a state that just lasts for years. Like it just stays there. It won't rot. Like they've been able to like put a plastic over it. Have you ever seen those
Hmm.
ones?
I mean, I know
No.
they preserved our cadavers, but I don't know about the plastic thing.
Yeah. There was like it's like you couldn't dig in, like it was set and stuff, like it was like set. Like
Oh,
yeah. But
okay.
it was real. It was a real person, like real faces, eyeballs, brain, like stuff like that,
Yeah.
tissue, hair, all that type of stuff. And then there were like wet cadavers. We would call the real cadavers like wet cadavers. So they were the ones that were like not that the other ones weren't real, but you kind of get what I'm saying.
Yeah.
They had a whole cadaver lab, so there was a mix between everything. There was like arms, heads, legs, torsos, and then like
Yeah.
full cadavers, and it was pretty intense actually. Like I'm not great with that type of stuff. Like I was talking to you before we went live about, I don't love horror movies or anything like that. So I don't want to say I have a weak stomach, but I'm not like great around stuff like that.
Mhm.
It was like
Yeah, I don't blame you. I'm actually pretty good like that. I don't know if I'm weird, but that stuff doesn't bother me. I like lived in the anatomy lab. I loved being in there. Um, but there was one girl in our group. One week we literally had to saw the skull in half. So I was sitting there with a handsaw at the top of
oh
this dude's head, just going to
oh
town. I had to saw the whole skull in half so we can open it like a watermelon. And and there was one girl in our class who really wasn't having it. She had to lead the class and she was crying.
yeah.
Um,
Yeah, we had
but
people like duck out of our labs and stuff. It's pretty full on. But as you said, it is really interesting seeing things in person because I ended up drawing pretty much everything in anatomy. My
mhm.
a lot of my stuff that I did, I ended up when I left sending it to the tutors, and it gets put up for students to this day to go through, because a lot of the drawings we would get sent
Mm.
from we would get sent drawings from textbooks that would be different to other textbooks. And you guys know this. Anyone that studied anatomy knows this. Every book's a bit different, right? Every
Yeah.
insert, like not every, but insertions, attachments, things like this, they're all a little bit different because there's variations even in people. And so I ended up drawing myself. I've got, like I showed it to you before, but I've got like my iPad and I got my pencil, and I would literally go through and just do everything myself until I understood exactly where things were, where they would
That's
lie.
awesome.
Yeah, because I just couldn't get my head around it, and we didn't have access to the cadaver lab full time. It was
Yeah.
scheduled, and most people would just be like, "Oh yeah, it attaches here," but then you say to them, "You're like, where does it really attach?" And they'd be like, "Well, it attaches to ABC, but where does that? Where is that? You know?" And people
Yeah.
wouldn't always have a full comprehension of it. And if you don't know if you don't know your physiology or your anatomy well, it's very, very hard to be really, really good at movement proficiency because you're dealing with various muscles and levers and systems, right? So I find that interesting. For someone that is just graduated, say they've
Mm.
graduated, I mean, it could be any like medical field. What would be your number one advice to someone that's just come out of a health degree and they're about to go in and start work? What would be your advice for them?
Now, if they're going to be anywhere in the field that treats orthopedic spine, if you have the capacity, read Low Back Disorders by McGill and just get your feet wet. You definitely didn't learn it in school. 100%. Even if you're a medical doctor, you did not learn this in school.
Big time.
um,
Even Kara's, we didn't
yeah.
hear about McGill, we didn't hear about McKinsey, we didn't hear about any of that stuff. What do you have any? Do you have a story that would come to mind about your experience with McGill when you went to his place?
I don't know if it's a specific story, but I mean, just watching McGill assess a patient is he has this idea of becoming a master at something. And when you see him work and you see him like just differentiating different tissues, this muscular, neural, fascial, and also including the psychological component and really giving the patient what they need, it's really a cool thing to watch. And it just makes you want to like become a better clinician.
Yeah, fair enough. I've seen some of those videos, and he's got his kind of like his office area, right, where he's got like the squat rack, and he's got his
Yeah.
models and things like that. And then is it the Gestalt podcast?
Yeah,
Gestalt?
he's been on there before.
Yeah,
Yeah.
because that's an MPI guy, right?
Yeah, Brett Winchester.
Yeah, Brett. And so I watched they had a two. Did you watch it? They had a 2-part podcast.
Yeah,
It's
I
like,
did. Yeah.
Well,
yeah,
I didn't watch it. I listened to it.
yeah, that was fantastic. I really enjoyed
It's funny.
that.
I think I've listened to McGill too much that like I just know it's like sometimes I know what he's gonna say,
Yeah.
or when he starts a story, I was like, I know where he's going with
Yeah.
this.
He has a lot of the same, he says a lot of the same stuff, and he's gotten really good at communicating the same thing. And he
Yeah.
doesn't go outside of that because he knows, like, he's actually careful what he says. Like, he knows not to overstep and say something that's not backed by his
Yeah.
research.
If he says something, he's looked at it and studied it himself, or he's seen it firsthand.
Yeah.
And that's what, yeah. Yeah.
So being a PAC, being a McGill certified practitioner and a powerlifter, what would you say to those people that are out there that say that lifting under load with a flex spine is A, not a problem, and B, some are even saying that it's more efficient and makes you more strong?
If they're able to, I mean, I guess you're talking about a clinician. Gift of injury is a good place to start. Unless you're ready to dive deep into, like literature, like scientific literature, I would start at gift of injury. See the story of Brian Carroll, how he, severely injured his back and how McGill rehabbed it. And the next step would be actually look at the literature for yourself. Read McGill's studies, read what other studies have to offer, and just immerse yourself in the literature. I mean, that's where you're going to find the answer, right?
Yeah, and it's being open to being wrong as well, I think, because if we're just as stubborn as the next person, like we're just as bad as the other side of people that are saying, so being able to appraise research is a skill that takes practice, and then even a skill that takes repetitive practice. It's something that I often say, everybody should be reading and trying to appraise research regularly, regardless of what you're doing within the healthcare system, especially if you're seeing patients. I know people are busy. I know that people don't have a lot of time, but it's just one of those things that is so beneficial, because if you're only reading articles and books, magazine articles and social media posts and books, textbooks and stuff, you're really reading someone's perception of research. So you got to be really careful, that you're not only reading someone's perception, even if it is McGill being as amazing as he is. I did things a little bit backwards. I actually immersed myself in the research first, and then I read McGill's stuff. So I did it a little bit backwards. And I wanted to do that so that I had a really good understanding of the overall breadth of knowledge and breadth of literature that is on the subject, and not just one way looking at it. But what I actually found, to be fair, is when I started reading lower back disorders, like, he's done a pretty comprehensive literature review himself. That's he's pretty much handpicked everything you need to know and just given it to you in a book. So I likely wasted a lot of time. But you know what I mean? Like, you just gotta, in my mind, I'm like, it's worth putting in the time, and it's worth actually having your eyeballs on the original study and being able to read it, and not just reading conclusions or abstracts.
Yeah, and just like a life perspective, not even when it comes to spine stuff, but like be ready to be wrong.
That's wisdom.
The being able to look at something and say I was wrong, that's huge. That's how you grow. I'll be wrong 1,000 times. I'm going to keep learning. That's where true learning comes.
The best people are, the people that are most successful have failed the most and have been wrong the most usually. And that's why they're so bloody good at what they do. The ability to change and pivot your opinion on something is incredibly important. And when you're seeing patients, it's even more important. Otherwise, you get stuck in the same old thought process. And the reality is that new research is coming out every day and every year. And so as professionals, we need to know that stuff. Anyway, hey, we'll let you go. But is there anything else you want to ask, Stephen, before we close?
I don't think so. Thank you so much, Matt.
I hope I gave you something where you can.
Right,
he's a magician.
There was so much good stuff in that, and I'm going to look forward to going through it all and editing it. We'll get some clips out on social media, but no, heaps of awesome stuff. So thank you so much for your time. I really appreciate it, especially for you. It's a Sunday night, and it's obviously usually family time, I'm guessing. So send my thanks to your wife as well. I absolutely understand what it's like.
Yeah.
We're really thankful that you came on, and you have a really unique perspective. So it's been fantastic, and I'm sure our listeners loved it. And all the best with your PA C stuff, all the best with your McGill stuff. Hopefully anyone that's listening to this that's in the region, feel free to reach out to Matthew, feel free to refer. As we talked about earlier in this podcast, the whole movement therapy thing is so airtight, so watertight in terms of an intervention. And even beyond that, the McGill stuff is just absolutely fantastic. It's like nothing else.
And I don't say this lightly when I say that, learning McGill stuff has completely changed not only my career but almost my life in a sense, because now I really do have a passion, whereas I didn't before, and my passion is actually helping patients who've been given no answers and have no hope, and actually being able to give them a shimmer of hope is light and day for some people.
It'd be awesome to have you even get involved with the CFMC, because we've just got a whole pool of people now accumulating throughout the world, like yourself, and the cross referral, even just talking about certain things and getting people's perspective on things is so helpful, so that'd be awesome.
I'd love to be a part of it.
Happy as, man. Thank you so much once again. Go be with your family. Have a fantastic Sunday night. What's the time for you? Is it like 6?
It's 6 o'clock here. Well, it was a pleasure talking with you guys, and I hope we stay in touch and for the long run.
Absolutely.
Since it seems like we're kind of a bit on an island here, so
it does. It really does. That's why we got to collaborate and stick together. All right, man. Thanks for your time. We really appreciate it. And see you, Stephen. Have a great night.
See ya. Thank you again.
All right, see you, sir.
All right, see you later.
Take care.